Hi, thank you for joining. We're going to just wait a few more minutes um, before we start to allow for more attendees. Thank you.
Welcome to the Hawaii Department of Health VFC virtual office hours this Tuesday, September 24, 2024. Today's webinar is about Nirsevimab updates, which will be presented by Josephine Araki, RN. Next slide, please. Just a few housekeeping information. Please ensure that you are muted throughout the presentation unless you are speaking. For QA team, please monitor the chat for questions you may be able to answer. And for reminder to attendees, today's session is being recorded. Slides and webinar recordings will be uploaded to our VFC website. To be added to the VFC program email list, please email your request to hawaiivfc@doh.hawaii.gov. In the subject line of the email, please write email list. Next slide, please. For any question during today's webinar, please use the chat to ask your questions to the Hawaii VFC program subject matter experts can respond directly. We will be answering your questions at the end of the presentation. Let me turn you over to Josephine.
Hi, my name is Josephine Araki. I'm one of the quality assurance assessors. Next slide, please. The objectives for today's webinar is to understand the RSV season in Hawaii, the appropriate immunizations for RSV prevention, and best practices for storing, handling, and administering these medications. Next slide, please. So the most common cause of hospitalization in infants is RSV. They're infected during their first year of life. The rate of RSV-associated hospitalization among infants born equal to or less than 30 weeks gestation, so premature infants, is 3 times that of the term infant. Prematurity is an important risk factor for RSV, and among preterm infants, those born at less than 29 weeks of gestation have one of the highest risks of severe morbidity and hospitalization from RSV. Next slide, please. RSV is the leading cause of hospitalization among healthy term infants. It can cause serious illness and death in infants and young children. Severe RSV lower respiratory tract infection can be prevented either by administering the monoclonal antibody, so that would be Nirsevimab or Palivizumab, or administering the RSV vaccine or Brisville during pregnancy. Next slide, please. So the RSV season for most of the country they have a set season, but in Hawaii, our RSV season is year-round. The graph that we have here, the data is as of September 19th. You can see from last winter, the RSV season was higher and then it went down during the spring and summer. But as of this month, there is an upward trend for RSV positive tests. Next slide, please. So RSV protection is recommended year-round in our state. Next slide, please. So, as I've mentioned, for protection from RSV, there are two injectable monoclonal antibody products, the Nirsevimab or Beyfortus and palivizumab or Synagis. They help protect infants and young children from lower respiratory tract infection caused by RSV. There is an RSV vaccine recommended for pregnant women to prevent severe RSV, lower respiratory tract infection in their infants, and that's called Abrysvo. Next slide, please. So I'm going to talk about Nirsevimab first. It is a monoclonal antibody that prevents severe RSV disease, as I mentioned. It's not a vaccine. It's a monoclonal antibody, and it doesn't activate the immune system like you would with an infection or vaccination and active immunization. These antibodies themselves protect against the disease. So it's more of a passive immunization. It's most effective the weeks after it's given, and its protection wanes over time. It doesn't provide long-term immunity to RSV, but provides protection to infants when they are at most risk. Because as children get older, they're less likely to get severe symptoms from RSV. Next slide, please. So Nirsevimab administration, you administer it IM. The preferred site is the anterolateral thigh region. You don't administer it through IV, ID, or sub-Q. So the number and timing of doses, infants younger than 8 months of age who were born during or are entering their first RSV season. So basically, as we mentioned, RSV season is year-round. So when they're born, they should receive Nirsevimab if the mother didn't receive the RSV vaccine or Abrysvo during pregnancy. The mother's RSV vaccination status is unknown, or the infant was born within 14 days of maternal RSV vaccination. Next slide, please. So the dosage for those that are ages less than 8 months, it's the 50 milligram for infants weighing less than 5 kilos, 100 milligram for infants weighing greater than 5 kilos, or if the infant is between the ages of 8 through 19 months, they get 200 milligrams administered as two 100 milligram injections in two different sites. Next slide, please. So the indications for Nirsevimab use for infants aged less than 8 months, as I had mentioned before, whose pregnant parent did not receive Abrysvo vaccine, whose pregnant parent's Abrysvo vaccination status is unknown, or who were born less than 14 days after the pregnant parent received the Abrysvo vaccination. Just to go over that again. And it's not needed for most infants that are less than 8 months whose pregnant parent received a Abrysvo vaccine more than or equal to 14 days before giving birth. Next slide, please. So Nirsevimab for infants born to vaccinated mothers. Nirsevimab may be considered for infants even if they're vaccinated, even if their mom received the vaccine, the Abrysvo vaccine, in rare circumstances. And this is based on the clinical judgment of the healthcare provider. So the benefit of having Nirsevimab may be warranted. So the situations where the infant may receive Nirsevimab, even though the mom received Abrysvo, would be infants born to pregnant women who might not have mounted an adequate immune response to vaccination, such as if they have an immunocompromising condition, or infants born to mothers who have conditions associated with reduced transplacental antibody transfer, such as those with HIV, infants who might have experienced loss of transplacentally acquired antibodies, such as if they went through a cardiopulmonary bypass or ECMO. Infants with substantially increased risk for severe RSV disease, such as if they have a congenital heart disease or if they're in the ICU and they require oxygen at hospital discharge. Next slide, please. So more indications for Nirsevimab use for infants and children 8 through 19 months of age who are at increased risk of severe RSV disease, including those recommended by the American Academy of Pediatricians, or AAP, to receive palivizumab or Synagis, regardless of RSV vaccination status of the parent. So those would be the infants and children with chronic lung disease of prematurity who required medical support, such as chronic corticosteroid therapy, diuretic therapy, or supplemental oxygen. Infants and children who are severely immunocompromised, and infants and children with cystic fibrosis who have severe lung disease, such as previous hospitalization for some kind of pulmonary exacerbation within their first year of life, or they have an abnormal chest x-ray that persists when you're stable, or they have weight for length that is less than the 10th percentile. Or if they are American Indian and Alaska Natives, as they have increased risk factors. Next slide, please. So administration considerations, you want to aim for giving Nirsevimab within the first week of life. For infants who are recommended to receive Nirsevimab, can be administered during hospitalization or in the outpatient setting. Infants who are in the hospital, who have a prolonged hospital stay because of prematurity or other causes, should receive Nirsevimab shortly before or pretty soon after discharge from the hospital. Nirsevimab should be administered to other eligible infants and toddlers as soon as Nirsevimab is available. Next slide, please. So administration considerations. If Nirsevimab supply is limited and the patient isn't eligible for palivizumab or Synagis, Nirsevimab should be prioritized to protect infants and children at the highest risk for severe RSV disease. First by their high-risk conditions and then by age, prioritizing the youngest first. Next slide, please. Nirsevimab can be administered with other routine childhood vaccines. They can be given on the same clinic day with other vaccine products, and there's no interval between Nirsevimab and live vaccines such as MMR and varicella. It's not expected to interfere with the immune response to vaccine products. So in clinical trials, when Nirsevimab was given at the same time with routine childhood vaccines, the safety and reactogenicity profile of the co-administration was similar to the childhood vaccines given alone. Next slide, please. Contraindications. It's contraindicated in infants and children with a history of hypersensitivity reactions, including anaphylaxis to the Nirsevimab alib or to a product component. Should be given with caution to infants and children with thrombocytopenia and any coagulation disorder, or if they're on an anticoagulation therapy. But any adverse reactions should be reported to VAERS, or the Vaccine Adverse Event Reporting System, through the telephone number shown or online at vaers.hhs.gov. Next slide, please. So for storage and handling for Nirsevimab, they are supplied as pre-filled syringes for one-time use, and there's the two doses, the 50 milligram and the 100 milligram. They should be stored refrigerated within the normal 2 degrees Celsius to 8 degrees Celsius, or 36 degrees Fahrenheit to 46 degrees Fahrenheit. may be kept at room temperature for a maximum of 8 hours. You should store it in the original carton to protect from light until use, and you don't want to freeze it or expose it to heat. And of course, as with everything else, don't use it beyond the expiration date printed on the label. Next slide, please. So ordering. Nirsevimab isn't ordered on HIR. It should be ordered through the Nirsevimab order form. And CDC has implemented a new top-off strategy for VFC Nirsevimab supply. What happens with that is they replenish doses allocated to our program every 2 weeks. So we're asking that you place your orders with our Hawaii VFC program so that we can ensure that we have the maximum amount of doses, CDC replenishment doses for our Hawaii VFC allocations every 2 weeks. With that said, though, and I don't have it listed on here, the 50 milligram doses are prioritized for our birthing hospitals, but the 100 milligram doses can be issued to either the hospitals or our other VFC providers. We do have a note, if Hawaii's VFC Nirsevimab allocation is above the CDC determined threshold, they're not going to give us any more doses. And if your VFC provider request exceeds available CDC VFC allocations, the VFC provider orders may be waitlisted and or partially fulfilled as we have as supply permits. Next slide, please. So ordering for birthing hospitals. Please continue to order the amount of VFC 50 milligram doses needed for a 2-week period, and we'll work with your facilities to distribute as many doses as possible for administration to the VFC eligible newborns. It is, I don't have it mentioned here, but it is VFC supply. I know with Hep B, we do issue it for private as well as VFC eligible children, but for Nirsevimab, it is a VFC program immunization. Next slide, please. So ordering for outpatient VFC providers, also the same, please order the amount of 100 milligram doses needed to immunize VFC eligible patient population aged 8 months or less and weighing greater than 5 kilos for a 1-month period. If your request exceeds available VFC allocation, same thing. Your order may be waitlisted and are processed for partial fulfillment as supply permits. Next slide, please. So talking about palivizumab or Synagist, if Nirsevimab is not available or not feasible to administer, high-risk infants who are recommended to receive palivizumab in the first or second year of life should receive it. I'm going to call it Synagist just because it's easier to say, until Nirsevimab becomes available. High-risk infants whose pregnant parent received a recommended RSV vaccine or a Brisville greater than 14 days prior to delivery should not receive Synagis except in rare circumstances. And it shouldn't be given to children who have already received Nirsevimab. Next slide, please. So it is a humanized mouse immunoglobulin monoclonal antibody. So it isn't a vaccine, same as the Nirsevimab. And 5 doses are administered IM at a dosage of 15 milligram per kilogram once per month. Next slide, please. I have it same here. Does not contain preservative and vial, cannot be stored once it is opened. Next slide, please. So for storage and handling, you store it in the refrigerator between 2 degrees Celsius and 8 degrees Celsius in its original container, and you don't freeze it. Next slide, please. Do not dilute it and do not shake or vigorously agitate the vial. Next slide, please. So considerations of palivizumab or Synagis versus Nirsevimab. administration for high-risk infants. So if Nirsevimab is administered, the Synagis shouldn't be administered. If less than 5 doses of Synagis were administered, the infant should receive 1 dose of Nirsevimab. No further Synagis should be administered. There's no minimum interval between the last dose of Synagis and the dose of Nirsevimab. And because protection from Synagis wanes after 30 days, Nirsevimab should be administered no later than 30 days after the last Synagis dose when possible. If Synagis was administered in the first year of life and the child is eligible for RSV prophylaxis in the second year of life, the child should receive Nirsevimab if available. If it is not available, Synagis should be administered as recommended. Next slide, please. So now we're going to talk about the maternal RSV vaccination or Abrysvo. And unlike Nirsevimab and Synagis, it is an actual vaccine, not a monoclonal antibody. It was approved by ACIP for pregnant VFC eligible children within guidelines. So they need to be 18 or under, uninsured, underinsured, Native American or Alaskan Native. So they still need to meet the VFC eligibility in order to receive the maternal RSV vaccination. And pregnant people should get a single dose of Pfizer's bivalent Abrysvo vaccine during 32 weeks through 36 weeks of gestation. To prevent severe RSV disease in infants, either maternal RSV vaccination or the infant immunization with the monoclonal antibody is recommended. Most infants don't need both. Next slide, please. So for administration of Abrysvo, as I mentioned before, they do get 1 dose between 32 weeks and 0 days through 36 weeks and 6 days gestation. Administer IM, preferred in the deltoid region of the upper arm. Same thing, you don't administer it IV, ID, or subQ. It's currently approved and recommended for administration as a single dose. Sufficient evidence does not exist at this time to determine the need for additional doses in subsequent pregnancies. Next slide, please. So administration with other vaccines. Pregnant people can receive RSV, DTaP, COVID-19, and flu vaccines at the same clinic visit when the vaccines are recommended. CDC's general best practice guidelines for immunizations indicate that age-appropriate vaccinations can be given at the same visit unless there's a specific reason not to. Next slide, please. So for storage and handling for Abrysvo, it does come in a vial of lyophilized antigen component. It's a powder, or a pre-filled syringe containing sterile water diluent component, not or, and a vial adapter. So you're going to mix it. Before reconstitution or mixing, you store vaccine and diluent refrigerated between 2 degrees Celsius and 8 degrees Celsius. You store it in their original package and keep them together in their refrigerator. Never freeze the vaccine or diluent. So after you mix it, you want to immediately administer the vaccine. You want to prepare the vaccine only when ready for use, because if you don't administer it immediately, you can't put it back in the refrigerator. That's different than other reconstituted vaccines. Typically, after you reconstitute it, you can store it, but this vaccine, you cannot put it back in the refrigerator. You store the reconstituted vaccine only at room temperature, and once it's mixed, you need to use it within 4 hours. Never freeze the vaccine or diluent once it's mixed. Next slide, please. These are references that I used for this presentation. Next slide, please. If you would like additional information, these are the links or the information on additional resources. Next slide, please. So we do have a post-webinar satisfaction survey. The corrected link, I do apologize. I'm not sure if this is the correct link that I have in the webinar, in the PowerPoint, but Kelohi did post it in our chat. We encourage you to please fill out the satisfaction survey so that we can get feedback on if you have a preferred date that you would rather we move our webinars to, or if there are certain topics that you'd like us to cover. Next slide, please. Do you have any questions? You can either unmute yourself or type your question in the chat. It is a little different with Nirsevimab for our state. Most guidance, if you view it online, it does speak to majority of our nation where they do have a set season, whereas our season is year-round. So if you do have any questions and you can't think of them at this moment or you think about it later, you can contact us. Next slide, please. Here's our contact information. So please feel free to contact us should you have any questions. Next slide, please. Thank you. Thank you for attending our webinar. If you don't have any questions, that's the end of our webinar. Thank you.